Charlie also co-founded and co-funded Explorus. It's now part of IBM in 2009 as a spinoff from the Cleveland Clinic. He is a frequent presenter and speaker at industry events such as NAMS, Health Unchanged, This Week in Health IT, and Cleveland Clinic Innovation Summit. Charlie, I'd like to turn it over to you.
Thank you, Delisa. Really appreciate it. I'm really excited today to go through some of our presentation. And let me just get my share screen going. Oh. There we go. Can everybody see that? Good. So, Delicia, thank you so much. Really appreciate having this time to speak with you all today. We appreciate that intro. This is something that, we started our company 3 years ago almost, and it has been a labor of love ever since. It's been a process that we built this very much inside the bubble with healthcare organizations, and most importantly, with MSPs like you. Such an important part of that. And, we've had so many incredible partners, MedStar, University Hospitals, Metro Health, and many others. And it's just, I would tell you that as I kick this thing off, the real intent is this is for you. In many ways, this is dedicated to you because you're such an important element of this. And I wanted to share some of the things we've learned along the way. So we're going to cover several items today. We're going to start with, in the beginning, we're going to start with identifying some challenges that healthcare administrators and just the healthcare system in general in the U.S. is facing right now. There is this widening gap between supply and demand, and it's going to cause a lot of challenges and problems over the course of the next few years that can be solved. And RPA and thinking about things from a different perspective, from a data standpoint, are going to have an impact on that. But I again want to first set the stage on what the environment looks like today and what it'll look like in the next 10 years. Then we're going to talk a little bit about robotic process automation, or just automation, right? And this is really about how automation with large data sets and large data networks provides better information for you to do your job. And in fact, in some degree, it begins to change things. So we're going to talk, a lot of times people are somewhat concerned about RPA. They say it's either new or it's something they're not familiar with, or is it a threat? The reality is it's neither. And we'll talk about why and why it's so important to the whole process around credentialing and other elements. We're also going to go into some depth around what does it mean for you? How does it change the way that you do work? How does it shift the balance back to being more of a knowledge worker, which many SPs started that way, but there's just overwhelmed with so many tasks. How do you get back to that point where you really can analyze things and use some of the skills that you've developed over your career? And lastly, we're going to sort of end it with you. What is the outlook for MSPs, and where do we see it evolving, and what kind of tools and things should you be thinking about as you build this thing out? But we'll start first with some challenges, and it is daunting, but the reality is there's ways to work through some of these things, and MSPs will be on the front line of how this is addressed. So supply and demand, you hear about it in economic models all the time, and much of this is not going to be new to you. We all know that since the 1900s, for instance, we've seen a very large growth in the population in the U.S. 1900 was around 70 million. Today it's around 330 million. It's projected to go even beyond that. But one of the things that's probably the most important to note about this graph is that if you look at the top two sections, the blue and the orange, those have continuously grown. That's 65 to 84 and 85 plus. That blue line wasn't even a line before 1960. Very, very, very small. And you'll see the orange section grow as well. And does it makes sense. People are living longer. There's better health care. The world, in some degree, in many ways, is a safer place. And so people are living longer. The challenge around that is that percent of the population, 65 or older, only makes up about 15%. But interestingly enough, they more than double that in their use of healthcare. That's important. We want that. But it does have as that continues to grow and more people fill, and that 15% number grows over time, that's something to think about relative to demand. Another element of demand is not just the aging of the population, but it's also how Americans are consuming healthcare. They are in some ways becoming more consumer driven about it. What does this mean? Well, people, as you know, are very interested in being able to have healthcare come to them. That's why telehealth has grown so much over the past few years. Now, granted, the pandemic has driven a lot of that. But the reality is that this has begun to change medicine, and it's changing credentialing to some degree and privileging, because there's so much more information about a clinician that's beginning to pile up because of the additional places they practice or have licenses in. But it goes beyond that. It also gets into other areas within healthcare that you're seeing a lot more demand. Retail health, being able to get parts of your healthcare at a retail pharmacy, for instance. We're kind of getting back full circle again to home health care. The doctor used to visit your home. Well, if it's not the doctor, it may be a nurse practitioner, it may be others that come. And that makes a lot of sense for a lot of the clinically integrated networks and ACOs to help manage chronic disease. Go to where the patient is. It's not all that crazy. We're seeing a lot of things begin to change. It's just societal thinking. It's just a few years ago, if you wanted to go out to dinner, you made a reservation and you drove to the restaurant and you sat down and ate it. In the past 2 years, you order it and someone delivers it via car to your house. Things have changed, and that's not going to change. The pandemic has really evolved thinking around not just other areas of the economy, but certainly healthcare. Now, that's the demand side. And by all measures, it's growing at very fast rates. Then there's the supply side. That's the clinicians, the roughly 16 million healthcare workers in the U.S., but also physicians and PAs and nurse practitioners and nurses. And the dynamics there are shifting, but unfortunately in the wrong direction. The gap is actually widening. There's a deficit forming. In the U.S., there are predictions that within just the physician population, the need and the growth will be upwards of 100,000 additional before 2034, so within 10, 12 years. And you probably heard this stat on the nursing front. There's a massive shortage. Arguably 1.2 million nurses will be needed within the next 10 years. That's a big number. As I mentioned, retirement just isn't about the patients as they age, it's also about the physicians. And this is an interesting stat. Two out of 5 active physicians today are going to be older than 65 within the next decade. That's 40% of the physician population. That's a big chunk. And when you're considering the demand rising really high, that's a lot to make up. In addition to that, just the size of the population changing, you have physicians that, when surveyed, pretty overwhelmingly say, I've almost had enough. This is really tough on me. The burnout is getting to me. In fact, a recent stat says that close to 4/5 of physicians who are surveyed say, I experience burnout almost every day. It's really prevalent, and it's a problem, and it's affecting my work. It's not what I signed up for. Working all these additional hours is tough. And it's beginning to reflect in some of the decisions that they're making. For instance, almost 50% of physicians, when they're asked, are you going to stick with this? They say, no, I'm probably going to make a career change sometime before I retire. That's pretty big. And if you look at even the past few years with the pandemic, we've had almost 1/5 of the healthcare workers quit their job. So you've got this massive demand that's growing really quickly, and you have the supply that's arguably shrinking. So it's going to get harder and harder. And it just means that the process of getting clinicians into an organization quickly and moved around an organization efficiently becomes more and more important. And it's no wonder, if you look at these stats, this is why there's a recent survey that was done by the American College of Healthcare Executives, where CEOs every year are asked, what are their top pressing problems? This year, It's staffing. How are we going to have enough people to meet this demand? And again, a lot of people say, well, that's just the pandemic. The trends don't spell that. They spell that it's going to be more. Sure, there's going to be an influx, but there's going to be more over time, and it's something that has to be a top priority for health systems and other organizations. So I talked a lot about the clinical side of the fence. What about administrative? Where's that? Well, that also has shortages in the horizon. In fact, medical and healthcare services and managers and people that are in that role, that's expected to grow 32% during this decade. They're adding today over 50,000 new openings a year in this area. So it's really important that we think about how do we optimize the things that we're doing. There's no shortage of work, but how can automation begin to optimize some of these things? You know, when we talk about shortages, one of the things that's really important to talk about is where is an organization with regards to capacity, or for that matter, overcapacity. Many of the health systems that I work with, of course, it depends on the service line, but generally speaking, they're operating in an overcapacity type situation, meaning people are working additional hours in many cases to meet demand. And that obviously has some negative effects. And at some point, it's not sustainable. If you think about the three elements of this that are so key, start with patients, right? If a patient can't get access to care, what do? They go somewhere else, or they don't get the care. And this is really important because if a patient goes somewhere else or doesn't get the care, outcomes suffer. If they go somewhere else, they call that leakage. They're going from one health system to another health system. And that creates continuity of care dysfunction. It breaks the chain. I'm sure they can take part of their medical record with them, but that relationship they have, because they couldn't be seen, breaks down. And we talk to a lot of healthcare executives who say, you know, what's driving your leakage rate? And they'll say, well, it's physician preference. Physicians are preferring to send their patients elsewhere. We got to do something about that. Well, when you ask the next question is, why are they doing that? The physicians say, because my patient can't be seen. They need to be seen right away for this. They don't want to wait 2 months. It's really important to them. So workforce intelligence, workforce management becomes really important to patients. Clinicians is another example. Deployment delays in getting, once you've identified a clinician to bring in the organization, whether they're employed or community, getting them deployed as quick as possible is really important for several reasons. There's obviously the clinician that's coming in. I've talked to some clinicians that literally, because of the time delays, had to go on COBRA between their own health insurance policies. And in some cases, some of those physicians fall out and they say, never mind. That's really important if you're trying to bring physicians in an organization to address overutilization and overcapacity. But also there's the clinicians that are there. I mean, there's almost even bigger challenge with that, because those physicians that are working those extra hours, those weekends, are waiting for someone to come in. They hear that someone's been identified, they've accepted the job, they want to get in, yet there are delays. And every one of those delays affects the burnout within that population. And then last, certainly not least, is the revenue element of this. Physicians, MDs, DOs, PAs, nurse practitioners, they bring in the revenue in a healthcare organization. And many healthcare organizations can't afford not to have this. It's really important that they offset their expenses with this. And when your average physician in the US generates about $2.4 million a year, or $9,000 a workday, every day that goes on where that capacity can't be filled is a day's worth of that revenue being lost. It's really important to the health of the organization. And so all of these sort of things come together to be pretty significant factors in not only the supply and demand, the supply chain, but also the velocity of the supply chain. And I'm sure it'd be good to hear from you after this. I'm sure there's a lot of MSPs that will tell you, wow, that's interesting, Charlie, but I'm not getting the budget I need. And it's just kind of ironic, because the reality is med staff budgets are really important. And if you look at some of the numbers that I just went through, the reality is it's almost like this underinvesting is stepping over dollars to pick up nickels because it has a really big effect. And so this is one of the things that, and happy to, well, we'll put my contact information in afterwards, but building really good return on investment models is something that's really key to making sure that your team is staffed, you have the right tools to do these kinds of things. And there's a lot of different ways to look at ROI. I would tell you the biggest caution is it is not a one-size-fits all. Different organizations are different. Capacity has a big impact on this and where they are. The percentage of physicians that are employed versus affiliated with the community, that's also a factor. There's a whole bunch of different things at play. But the reality is just a little movement, just a little bit of improvement in the time that you get a clinician in an organization can have a very profound effect. For instance, if you can just shave 10 days off the process by automating components of it, it can have a massive impact. 10 days with an organization that brings in 500 new clinicians a year equals 5,000 days of savings. That in essence, 13 and a half years. That's a really big number. And these are the kinds of things, again, it depends on your organization, but as you build and justify and ask for your budgets, it's really important to bring this kind of information to the table because it's really important. So I sort of set the ground for where things are today and where they are going fairly quickly. Now I want to talk a little bit about what this RPA stuff is, robotic process automation. And it's to be honest, it's not all that new, and I'll explain why in a bit here. It's also not very scary. It really is empowering. It's essentially automation, and you're doing some of this today. But it is something that is really has to be on the forefront for most organizations. But before I get started, I want to talk about a few terms. You probably heard the word workforce intelligence. We characterize our company as being in this space. And workforce intelligence, in essence, is pretty simple. It is having all the information that you need, or any decision maker for that matter needs, to make the right and fast decision about onboarding an employee, a clinician, or whoever that might be. And that is a lot of different things. And by the way, that could be privileging as well, not just employed, but getting a community physician privileges. You got to be able to make these decisions, and you got to have a large set of data. The data is piling up pretty fast. I'm going to go through some examples of this. But obviously, the more data you have, the more information, the more primary source verification you get in, the more a higher resolution picture you have. It's like going from standard definition TV to high definition. You see more in that. And that's really important in the process. It's also really important that if you have clinical workforce intelligence, it can't just be a point in time. It has to be something that over time is continuous. And this is something that for a lot of people, it's a little bit hard to grasp because this is not the way it's been done in the past. It's especially onboarding and privileging. It's kind of something that's done either once and then it's done 2 years or so later, and then it's on and that kind of a cadence. But the reality, for the organization needs to make movement around putting people in the right place at the right time, you need to have that information up to date immediately. And if there's so much information changing about a clinician, even during the 60 or 90 days of process between getting them in and enrolled, a lot can change. So when we think about workforce intelligence, a requirement is that it's current as much as yesterday, where that's appropriate. It's also obviously independently verified. Getting to that, nothing has changed here with regards to what Joint Commission and NCQA require that they go to either the primary source itself or a primary source equivalent. Those are sort of ordained and defined pretty well. That's really important here, that it's those sources that you're getting that information from, not an aggregate of an aggregate of an aggregate. That's really key. The physician, obviously, as you all know, or clinician, their role in this is really important. Because that's the only one person knows how to pull and curate their data better than you do. That's the clinician, because they've lived it their entire career. So having them not only attest to information, but be part of the process is something that's really key and an important element of workforce intelligence because it's really about them. And then obviously always expanding. We'll talk about what this means, but the expansion rate is something that's happening so fast. For some people, they're not recognizing how quick it is. In many cases, how owners can be over time. So if you think about workforce intelligence is driving better, faster decisions. And those decisions really feed sort of the tree of life for a health system. Physicians, MDs, DOs, clinicians, nurses, they are the lifeblood of an organization. And so having information that you can bring in from not just inside your organization, but outside. I mean, you all know this stuff changes really quickly, even for physicians that are placed already in practice. Having good information where you can do effective planning. Do we need to move? Can we move clinicians around before we go hire them? Is that an option? Where is burnout? That sort of kind of information is really key. Recruiting is another. If you can bring information and robotic processing to bear and make it easier on a clinician who's applying, it gets them through the process a lot faster. It reduces the time. And we see this in other industries as well. You can buy insurance in less than 15 minutes. You've got things like Rocket Mortgage to sign up for a mortgage really quickly. Leaders in the space are beginning to think about how do we take that experience of the people that need to get us information and how do we reduce the barriers and the friction associated with it. Obviously, this information is critical for credentialing, for privileging. Enrollment's another. It's really important to have all the information that a payer needs so that you don't have to go back and forth with that payer or health plan. That's really key. Obviously, deployment and evaluation. Constant reevaluation, whether that's OPP or FPPE and the other things around that, continuous monitoring. So information, particularly information from outside your organization, is really key to growing that tree. Now, robotic process automation, I'm going to talk just a little bit about that for a moment here. And again, it's not all that new, and I'll show some examples of it. It's just been in different forms over the literally centuries. But in modern day, it's oftentimes thought of as bots. I use the word bot. It sounds kind of cute, but it's basically robotic process automation, and it's really about automating repetitive tasks. And that automation can happen in a number of ways. It can happen in a really simple way, or it could happen in a cascading logic, so that, for instance, if a clinician reports one thing, then two other things are checked, or vice versa. Or it could be really sophisticated. It could be artificial intelligence where the system's actually learning on itself. But by and large, even in those situations, it requires instructions. And it's only as smart as its teachers. But once it's taught, once you put it to work, it never forgets. It never gets tired. It pretty much won't miss anything because it's programmed to see it every single time. It documents everything it does, which is really important for auditors and surveyors. But again, the key here is that the human in the middle is always going to be important. And again, it's required. Whether it's Joint Commission or NCQA or URAC, you have to have someone looking at this. It's essentially serving you. And a lot of times you talk about, why it's not threatening. And this is kind of a good, really old example of this. It's the sheepdog and the sheeps. And the sheep, in that kind of a scenario, if you think about it, the sheepdog wasn't a threat to the shepherd. The sheepdog actually allowed the shepherd to do more. It allowed the shepherd to focus on the danger around them, whether that's wolves or sheep wandering into the wrong areas. This was really important. Robotic process automation is also almost everywhere we look today. If you fly commercially today, you're going to have a pilot or pilots that are still in the cockpit. They don't take them out, but they are aided by a wealth of information to reduce their overload, manage the tasks. That's really important. If you have a relatively late model car, you've probably seen this. You go to flip your turn signal on, you start moving over a lane, it starts beeping at you. That's RPA. It isn't driving the car for you, at least not yet, but what it's doing essentially is it's helping you in the process. If you come up on a car really quickly, in some cases it's going to apply the brakes. Same thing with backing up. These are the things that we see every day. And by the way, That's just simple acknowledgement here. You're using some of this today. Almost every MSP that we work with is applying everywhere they can web crawlers. So it's not new. It's an important element of how things work. But we are beginning to see things evolve from just a point of time to always on, always looking. And again, continuous monitoring has been happening for a long time. NPDB, continuous monitoring, is a good example of this. But why stop at adverse events? Why not go beyond that? Look at the new stuff that's coming through: licenses, certifications, affiliations. All of these things, as they come into the system, make a clinician more deployable. It teaches you about your network, and that's one of the things that's really important along the way. So again, RPA is about human enablement. It's not about replacement. Another thing that's really important is RPA is also not about replacing the systems you have now. It's not about replacing your provider data management platform, which you use for credentialing and privileging today. Those are your back office systems. That's your system of record. Now, you may be upgrading some of those things, but still, those are set processes. A lot of thought went into that. Don't change that. This is really just enabling those systems and you with access to information. In many ways, a more expansive set of information where bots are constantly getting that information and bringing it into your system. So that's something we see as really important in the process. Also, in addition to all the external data sources that may be out there, one of the ones that are really probably most important is the clinician themselves. It's about them to begin with. We had a clinician say to us a couple years ago when we were building a solution together with one of the health systems, and he said, credentialing's always been one of those things I've dreaded because it's always done to me instead of with me. Golly, if you just cue me in and help me provide you better information, I will. I want this done as fast as possible, and so do you. Just make it easy on me. And that's why RPA applied also to the clinician experience is really important. We're seeing in the industry an average of around 3 weeks to get an application back from a clinician. Why? Because a lot of times it's not pre-formed. It's fill it in from scratch. That could take a couple hours. They got to go find stuff. They got to go look for it. And then they find a weekend where they can pull it off and they send it to you and they leave something out. It just happens. I'm sure you've all seen this. Clinicians don't like filling out forms and they're really not that good at it. So why don't we flip the paradigm? Why don't we allow RPA and access to primary sources to feed that experience? So when that clinician goes in and begins that application process, now 90% of those forms are filled in for them. They're just saying, yes, that's right, that's right. Of course, if anything's not, they can attest, they can counter it. But that ability to get through that is really important because it reduces the mistakes. It reduces the back and forth. It reduces the omissions that happen, whether those omissions are unintended or intended. It provides much faster turnaround, which is key. And also, clinicians love it. They really like it. It's something that just makes their life easier. So next, I want to talk a little bit about what impact this has on an MSP, almost from in a daily activity perspective. And I'm just going to stress the point again about this ever expanding, like the universe is ever expanding. Well, the amount of information from a primary source perspective that has to be collected is also expanding very quickly. And I'll use some examples. In one, I talked about telehealth before, and telehealth is so popular for so many reasons. Certainly certain service lines are aligned really well with it. It's a perfect fit. Behavioral science, behavioral health and things like that. You've got portions of primary care. Obviously, care management is really important. By the way, it's not just provider to patient. It can also be provider to provider. In many cases, health systems, especially in rural areas, don't have coverage. And this gives the ability to virtually have consults, virtually provide ICU care. So it's coming pretty fast. But it's changing a lot of things because just not that many years ago, your average clinician in a health system practiced in one, maybe they practiced in a few states around where that health system. But now those clinicians that practice in telehealth are practicing in upwards of 30, 40, sometimes 50 different states, because those telehealth organizations need that. They need to be able to build their inventory of clinicians and that can work as many places as possible. So now you've got clinicians that have licenses all over the place. Of course, they're not coterminous. They're expiring all the different months of the year and everything else. There's a lot to go on. And there's also the adverse events, things that you want to look for. It's constantly getting added. Even during the course of credentialing someone, they could get 3 more licenses in that time. So having that real-time, up-to-date information is really important. And it's really hard to keep up with if you're not leveraging bots. And again, it's not just telehealth. You've got the same challenges with the proliferation of care into some of the physical spaces within healthcare. So all these channels are changing over time. It makes for a puzzle that keeps getting bigger. It keeps getting more complex. It's hard to keep up with. So one of the things that if you look at how things are beginning to change and just the sheer magnitude of the data that's beginning to pile up, it's become clear. A lot of MSPs that I've talked to are like, so much of my day is spent tracking down stuff. It is my day is not spent using my brain and all my experience and intellect that I've built over the years. I'm shoveling data around. I don't have as much time for the brain activities, right? For the things that really take, all the things that if you've been a MSP for 20 or 30 years, you have an incredible wealth of information. But the problem is if you've got tasks coming in at you at 100 miles an hour, it makes things pretty tough. And from an organizational standpoint, you're much more valuable in an organization if you can automate the trivial things and really focus on the stuff that's harder. And you know what these are. First off, not every PSV can be automated. Some of them are still manual, so there's still some of that, and that'll probably change over time. But the things that won't change is where human intellect and experience around these things can detect and make sense of some of these things. And it's just so incredibly important. You take red flag indicators. You got application data that came through, it doesn't match the PSV. There may be a really good reason for that, but it needs some explanation or needs some looking into. You could have robotic process automation enforce that someone fills in and defines a gap in work history, but it doesn't mean the gap, that the definition or the explanation is satisfactory. It may lead to some other questions that have to happen. Unusual work history, unusual affiliations that just don't seem to make sense in that case. Why is a clinician moving around so much? Oh, it's because they're a locum, or maybe they're not. So what is that? Medical malpractice claims, yeah, NPDB will give you that information in a feed, but many of the organizations we work with also want to get that information that hasn't been adjudicated yet, those claims, and that COI information directly from the carriers. There's an element too. Again, some of that's being automated, but still, those are some of the cognitive elements that are just really important in the process and oftentimes get crowded out because there's just so much remedial task coming at you. So lastly, I want to talk a little bit about the value add in what this can mean for you in your career. The reality is that, and I shared some examples on credentialing and how credentialing can be aided by bots where you can spend more time in the cognitive elements of these things. That's really important. A lot more analysis work has to go into that. If you think about it, that's how some of you who have been in this for a while with the test used to be able to do a lot more of that. That kind of stuff is really important. And by the way, it's what's appealing to the new generations. They want to work on that. But, in my opinion, that we've heard this from others, is that the role of the MSP is going to expand. And why? Because you've got a wealth of information and knowledge that if you're taught how to use some of these tools, you become proficient in some of these analytic tools, and they're not as hard as they used to be, it begins to change the game. You know more about clinicians than anybody in many of these cases. So why not have MSPs be front and center on workforce analytics? Not just on the people that are coming in or getting reappointed, but how an organization to think about moving its resources around. Also network planning. To that effect, where do we plan? How do we build a network? This isn't just about how a health plan builds a network. A health system has to do it too. And sometimes it means using their own people. Sometimes it's using augmenting with certain staffing firms. Sometimes it's care collaboratives. All of these things are really important. Why not have the MSP be part of this? Why leave all that knowledge on the table? It's really important. And if you think about just some examples where MSPs can get involved, it's things like asking these questions that are very difficult to solve. And a lot of times, organizations only answer these questions once a year. There's no culture around this because it takes a long time to get this together. But if data's coming in constantly, it's all being updated, and you've got the tools for it, think about how you can begin to answer questions like, what are the relationship between supply and demand? Is it isolated? Is it just in this location, or is it just a service line or specialty? Or is it pervasive? And how do we address it? Should we bring more staffing firms to bear? Should we bring more locum? Or can we have the people to do it already? What are your gaps in care? Where do they exist inside the network? Where are patients going elsewhere or not getting the care at all? What kind of capacity is in the organization at a service line, at a provider type? What does your organization look like compared to the provider-verse around it? Those clinicians that aren't affiliated with your organization. What percentage is that? Is there opportunity to grow, or do you really have to double down on doing things internally and automating? How does this affect burnout? What opportunities exist to partner with other healthcare organizations? We're seeing a lot of this. Up here in Northeast Ohio, we've got 2 health systems that are working together to meet community demand and community need. They've got portal credentials that go back and forth. That's really exciting. And that, again, was done because they were able to look at some of these things and apply some of this knowledge. How often can your organization, to what degree can your organization build a telehealth presence? You know, what's interesting is telehealth was one of those things that had some challenge with regards to reimbursement. So a lot of large health systems say, we're going to kind of sit on the sidelines on this. We're not really sure how this fits. And meanwhile, you had big organizations grow telehealth practices. And it was tough for them because they didn't have the physicians. They had to hire them. But health systems do. And now with reimbursements changing, how can a health system or multiple health systems across the country band together to provide a national telehealth presence? And again, to do that, there's an element of credentialing across all of them that's really important, but also an element of understanding that workforce. So, you know, what does this mean for the future MSP? It's a pretty bright future. And the reality is, and you've known this, MSPs have never been more critical to an organization. They're the first step in patient safety. You're the first step in the revenue cycle process. And the more that you can give as it relates to insight into how a population of clinicians operate within your organization, the even more valuable you become. And again, the trends continue to go in the right direction. The Bureau of Labor Statistics is estimating that in the next decade, there'll be a 25% growth among operations research analysts. That's overall. But the reality here is these are the kinds of things that are really important. Operations in a healthcare system revolves around the people. It's a people product. So that's absolutely key. So this bodes really well. And I would tell you, it isn't just good news for the MSPs early on in their career. It's also really good news for the MSPs later on in their career. Because at some point you may want to retire, that's fine, but I know a lot that still work in the workforce. They want to consult. They want to be part of organizations like Hardenbergh. And I'll tell you that in those cases, the knowledge that they have about the inner workings of this are really key. You combine that with some data analytics, and that can tell organizations things that they never knew before. So you've got this opportunity to not only, if you're early on in your career, really get to where the whole industry is moving, but also if you're the later part of your career, you can extend it in many ways. So it's just something that's really good. And lastly, and we'll put my contact information in afterwards. Again, this stuff isn't as scary as it looks. There have been so many advancements within analytic tools over the past few years. They've really brought this, out of the realm of you had to be a complete techie to use them to making them a lot easier to use, where just the average person can run analytics on some things. And so there's a lot of resources out there. A lot of them are free. YouTube's got tutorials around this that range from everything from from 6 hours to 6 days to a month. Some of it's free, some of it's paid for, but in either way, it's really important. In addition to that, some of those resources you can find, and you can click on these links, is the ROI side of things. And again, this is one of the things I just think is just incredibly important. Your role in the organization is so critical to the success and the financial success of a health system and all the other mission elements that it's trying to drive. Use those ROI, use those calculators, because you can't argue with facts. And that really helps as you build out your budget, because you deserve it and you need it. And I, as a patient at times, say, I need it too. We all need it. So it's really key. So with that, I think we'll start some QA. Again, I want to thank you. It's such an honor to talk to you today. I'm really excited to hear about some of your perspectives or questions, and hope we can answer them.
Charlie, thank you so much for that great presentation. We really appreciate it. We have a couple of questions. One, how important would you say the quality of your data is to effectively using these RPA processes?
Yeah, great question. I think quality data is one of those things. First off, you typically want to get it you need to get it from the primary sources where that's required. And automation of those primary sources, they're not always right either. It's not common, but there are times when it's not right. And I think that's where having the clinician in the middle, again, nobody can curate a clinician's career information better than they can. And having that ability for them to have a look at it as well. Obviously, when you begin to see inconsistencies, you address them. You see this today. And again, our philosophy is always correct it at the source. Otherwise, it's going to be a repeating process. A lot of times it gets corrected in the provider data management platform, which is fine, but it's just going to come back to haunt you again. And so, quality is something that's obviously really important. I think, luckily a lot of this information is discrete, meaning it's in certain fields. It doesn't have to necessarily use natural language processing like some medical records do. So it's a little bit easier to manage, but I think that's key. And then the other element of it is this too. If you're going to digitize, and we learned this from the very beginning, we call it don't be too cool for old school. So what does that mean? Old school is the original artifact that you're used to seeing. It's the actual screenshot of the medical license, state medical license. And when we looked at that from a software engineering standpoint, we're like, wow, what do you need that for? You have this. Well, it's important. It's important to have both. And so that's part of that quality journey that's really key. Excellent, thank you.
Given that blockchain is effective for routine, predictable transactions and credentialing, how do you see it working with RPA?
That's a great question, Delisha. I think blockchain is one of those things that a lot of times people sort of misunderstand, and they say, okay, we can put all these credentials in the blockchain. That's not a good idea. The blockchain is immutable, which is a good thing about the blockchain. It can't be changed. And it's a ledger system around that supports that. But there are certain things that just by virtue of some of the privacy laws, whether it's GDPR or CCPA or just your policies, where if you have to fix something, you'd want to be able to fix it. And so storing things on the blockchain is something that's can be a no-no in some cases. But where it fits in RPA is being able to verify, and where we, for instance, use the blockchain, is being able to know that this particular proof, this primary source verification, did indeed come from that anointed source. And in that process, it also has not been tampered with. That seal, that shell around that proof is really important. And when you're able to put that shell around, you combine RPA with that, you're able to rapidly produce some of these things. And it gets back to the same question before of, how do you improve quality? Blockchain doesn't necessarily change the quality, but you know that artifact, it has a link back to know that it hasn't been changed, it hasn't been altered, and it came from the right source.
Great, thank you. We have one last question. Do you have any recommendations for an MSP data analyst position, sort of like a job description or a template for such a position?
Yeah, absolutely. I mean, we, the elements of the MSP are still important, right? And so just take that as the base. That's a must-have. And as you've probably seen, it takes a long time to onboard someone and get someone up to speed to become an MSP. If they haven't done it before, it's like maybe a year-long learning curve. So that stuff's really important. But in addition to that, it's really about, okay, how does this person want to be a knowledge worker? And how do they want to take the information that's coming through and apply it to really providing insight to the data as opposed to just pushing paper around? And really nobody wants to do that anymore. And so I think developing in that skill set, in that job description, those elements of being comfortable with data analysis. You can train these things. I mean, just be clear here. You don't necessarily have to look for people that have years of experience in these analytic tools. I mean, that's my whole point here. They're getting so good and easy to use that month and you're up to speed. And again, this is why if you have those MSP skills to begin with, you layer that on top of it, and you've got a really probably happy employee and a really productive one at that.
Great, thank you so much, Charlie.
Yeah, Alicia.
We have one more question. Someone's asking what your opinion of CAQH is in working with these processes.
Yeah, it's interesting. I mean, CAQH has done, the idea that they brought this universal app to the enrollment process was a really important achievement. I think the challenges with CAQH in many cases, though, is that information is really hard to keep up. Clinicians aren't crazy about it's very manual. Clinicians aren't crazy about going in there. Oftentimes they don't. Often it's the MSP or someone within the physician's office that has to do it on their behalf. That becomes like the telephone game, right? Nobody can document their career better than that person. And so I think over time, and I think they get this, being them as well, being connected into these data networks is really key. So that you apply the RPA to that application, you keep that information up to date. And so as payers connect into that, they have that most up-to-date information as well during the enrollment process. Of course, it's a little different for some health systems that are delegated. You're more of a rostering model, but that said, I think that's my opinion is I'd be really excited to see that go to the next level and tap into some of these robotic process automation and data sources and data networks that are behind it. Great question.
Great. If there are no further questions, I want to thank everyone for attending today. And, we have some contact information here. You can reach Charlie on his LinkedIn information, and we will be sharing these slides after, in addition to your certificates within 48 hours of today's presentation. If you are interested in additional Hardenbergh presentations, we do have one coming up in March regarding provider data integrity and provider data governance. So we'd welcome you to join us at that time. Thank you everyone for joining us today. We value your participation.